Welcome to this video on gas exchange, focusing on conditions like COPD, asthma, SIDS, and RSV. This is for NUR 102. We begin with chronic obstructive pulmonary disease, or COPD, which causes chronic obstruction and leads to air trapping. It includes emphysema and chronic bronchitis. Key risk factors are smoking and AAT deficiency, with tobacco smoke accounting for 90% of cases. A focused respiratory assessment for COPD involves collecting data on risk factors, subjective and objective findings, and a thorough client history. We will also discuss the necessary lab tests and diagnostic procedures in more detail. This image highlights common symptoms of COPD, such as chronic cough, wheezing, barrel chest, and prolonged expiratory time. Patients may also exhibit digital clubbing and use accessory muscles to breathe. The signs and symptoms of COPD can be summarized with the acronym lung damage. This includes lack of energy, unable to tolerate activity, poor nutrition, abnormal blood gases, dry or productive cough, increased anteroposterior diameter, skin color changes, abnormal lung sounds, tripod positioning, and extreme dyspnea. Diagnostic tests for COPD include ABGs, serum electrolytes, CBC, and sputum cultures. Pulmonary function tests, or PFTs, such as FEV and FVC, are crucial. Imaging includes chest X-rays and CT scans. Spirometry and AAT levels are also important. Complications of COPD include progression to heart disease, such as congestive heart failure. Other risks are pneumothorax, frequent lung infections, and an increased risk of lung cancer. Emphysema is characterized by the destruction of alveoli, leading to decreased surface area for gas exchange, CO2 retention, and respiratory acidosis. The two major changes are loss of lung elasticity and hyperinflation of the lung tissue. Patients are often referred to as pink puffers. The pink puffer presentation in emphysema is associated with increased CO2 retention, leading to a pink appearance, pursed lip breathing, barrel chest, and use of accessory muscles to breathe. They often speak in short, jerky sentences. Chronic bronchitis is an inflammation of the bronchi and bronchioles from chronic irritant exposure. It causes excessive, thick mucus secretion and a productive cough for over 3 months, 2 years in a row. It is associated with decreased ability to exhale fully, and patients are often called blue bloaters. The blue bloater presentation is characterized by dusky to cyanotic color, recurrent cough with increased sputum production, hypoxia, and hypercapnia. These individuals also show signs of right-sided heart failure and use accessory muscles for breathing. The primary risk factors for COPD include advanced age and smoking. Secondary risks are secondhand smoke exposure, air pollution, occupational pollutants, and a family history. Alpha-1 antitrypsin deficiency is also a factor. Nursing care for COPD involves monitoring the respiratory system and positioning the client in high Fowlers. Interventions include deep breathing exercises, such as pursed lip breathing, oxygen therapy, medications, proper nutrition, and chest physiotherapy. Medications for COPD primarily include bronchodilators, such as beta-2 agonists and anticholinergics. Anti-inflammatory agents like steroids and leukotriene antagonists are also used, along with mucolytic agents to manage secretions. Teamwork and collaboration are essential for managing COPD. This includes working with respiratory therapy for chest physiotherapy, nutritional services for proper diet, and rehabilitation care for conditioning. Education is crucial for managing COPD. Advise clients to avoid sick people and environmental irritants. They should stop smoking and avoid secondhand smoke. Rest as needed, take measures to prevent infection, and use oxygen as prescribed. Asthma is a chronic obstructive disorder of the airways that can occur at any age. It can range from mild to life-threatening. Variations in development, persistence, and severity exist, with a greater incidence in African Americans. The pathophysiology of asthma is complex, with an unknown cause, resulting in inflammation or hyperresponsiveness. It is triggered by allergens or irritants and can be exacerbated by emotions like stress or fear. Airways constrict, become edematous, and excess, tenacious mucus is produced. This illustration summarizes the signs of an asthma attack, including wheezing, shortness of breath, increased mucus, and coughing. Severe cases can lead to CO2 retention and are considered a medical emergency requiring immediate attention. Risk factors for asthma include older adults, family history, and allergies. Other factors are GERD, smoking or exposure to secondhand smoke, and exposure to chemical irritants or dust. Common asthma triggers include allergies, respiratory infections, and exercise. Exposure to irritants, weather changes, emotional distress, certain medications, and food additives or preservatives can also trigger an attack. Signs and symptoms of asthma include wheezing, coarse lung sounds, and shortness of breath. Patients may also experience a cough with mucus, chest tightness, and use of accessory muscles. Children may complain of itching of the chin, neck, or chest. Consider the following nursing care plan case study. Riley, a 4-year-old recently diagnosed with asthma, lives in a home with pets, a smoking mother, and carpeted floors. This presents multiple potential triggers. In Riley's case, a teaching plan should reinforce instructions on recognizing signs and symptoms, preventing exacerbation, and proper medication use. This includes addressing environmental triggers, physical activity, and the use of a peak flow meter. Diagnostic tests for asthma include pulmonary function tests, which are most accurate for diagnosing and assessing severity, such as FVC and FEV1. Other tests are bronchoprovocation testing, skin prick testing, chest X-rays, and ABGs. A safety alert for asthma is that shortness of breath, restricted breath sounds, and a rising respiratory rate can indicate imminent respiratory failure. These signs should be reported immediately to a healthcare provider. Asthma nursing care involves monitoring cardiac and respiratory systems and positioning the client in high Fowlers. Other interventions include oxygen therapy, avoiding triggers, and medication administration. Maintaining a calm demeanor and providing rest are also vital. Asthma maintenance medications include inhaled corticosteroids such as fluticasone and budesonide, and injections like omalizumab. Long-acting beta-2 agonists like salmeterol Ginoforte help to improve overall asthma control. Further maintenance medications include anticholinergics such as ipratropium and tiotropium, which reduce inflammation and mucus. Xanthines, like theophylline, relax airway muscles, and leukotriene modifiers, like montelukast, reduce inflammation. Rescue medications include short-acting beta-2 agonists like albuterol, which rapidly dilate the bronchi. Oral and IV corticosteroids, such as prednisone, may be used for severe cases. Metered dose inhalers are frequently used for quick relief medication. Education for asthma management involves self-monitoring using a peak flow meter and an asthma action plan. Clients should understand how to use metered dose inhalers and nebulizers. Avoiding triggers, preventing infections, and proper diet are also important. A peak flow meter is used to measure the fastest rate of air a person can blow out after maximum inhalation. It helps to monitor lung function and identify worsening asthma. It is used in conjunction with the Asthma Action Plan. The Asthma Action Plan uses a traffic light system to guide management. Green means controlled, yellow means caution and use of rescue meds is needed, and red means medical alert and immediate treatment or emergency care is required. Complications of asthma include respiratory failure from persistent hypoxemia and status asthmaticus. Status asthmaticus is severe, persistent bronchospasm that can lead to right-sided heart failure, pneumothorax, and respiratory or cardiac arrest. For status asthmaticus, interventions include administering oxygen, bronchodilators, epinephrine, and systemic steroid therapy. Be prepared for emergency intubation, as this condition can involve extreme wheezing and labored breathing. Teamwork and collaboration in asthma care often involve respiratory therapy for breathing treatments, a dietitian for nutritional guidance, and occupational or physical therapy for activity planning and conditioning. Respiratory syncytial virus, or RSV, is a common virus that typically causes mild cold-like symptoms. While most people recover quickly, it can be serious for infants and older adults. RSV is the most common cause of bronchiolitis and pneumonia in children younger than 1 year in the United States. It is also a significant cause of respiratory illness in older adults. Signs and symptoms of RSV include fever, cough, and a runny nose. Individuals may also experience a decrease in appetite and activity, tachypnea, tachycardia, and abnormal lung sounds like wheezes or rales. RSV is transmitted through direct contact with respiratory secretions and indirectly through contaminated surfaces. It is not spread via the airborne route. The incubation period is typically 2 to 8 days. Treatment for RSV includes contact isolation, rest, and maintaining high humidity. Ensure adequate fluid intake, monitor input and output, and administer oxygen if needed, while continuously monitoring oxygen saturation. Suctioning may be necessary. Sudden infant death syndrome, or SIDS, is the sudden, unexpected, and unexplained death of an apparently healthy infant under the age of 1. Most cases occur within the first 6 months, peaking at 2 to 4 months. The Safe to Sleep campaign promotes practices to reduce SIDS risk, such as placing infants on their back to sleep. A thorough investigation is required to determine the cause of death. Clinical manifestations of SIDS include death occurring during sleep without an audible cry or signs of distress. Management focuses on providing emotional support to families. Prevention strategies include educating parents on safe sleep environments. Chest tubes are inserted for continuous drainage of blood, fluid, or air from the pleural cavity or to instill medications. Indications include pneumothorax and hemothorax.